Hi everyone and welcome to this video on buccal bifurcation cysts. Today we'll be discussing these cysts, including what they are and how they form, the signs and symptoms to watch out for, diagnosis and treatment options, prognosis and how to maintain good oral health after treatment. By the end of this video, you'll have a better understanding of buccal bifurcation cysts and feel empowered to discuss any concerns you may have with your dentist. So, let's get started. The epithelial lining of the buccal bifurcation cyst is probably derived from the epithelial cell rests of malices in bifurcation of multi-rooted teeth. The histopathologic characteristics of the lining are not distinctive and overlap with other odontogenic cysts. Therefore, both histopathologic and radiologic examinations are necessary to make the appropriate diagnosis. The etiology of the buccal bifurcation cyst is not known. One hypothesis identifies inflammation as the stimulus for epithelial proliferation, but inflammation is not always present. It is possible that the parodental cyst of the third molar and the buccal bifurcation cyst are the same entity. An associated enamel extension into the furcation of third molars with parodental cysts has not been documented with molars with buccal bifurcation cyst. In addition, the inflammatory component associated with parodental cysts is not always present with buccal bifurcation cysts. Commonly, the buccal bifurcation cyst is associated with mandibular molars. They can also arise in association with maxillary molar teeth. On clinical examination, the molar may be unerupted or the tooth may be partially erupted with its lingual cusp tips abnormally protruding through the mucosa, higher than the position of the buccal cusps. The first molar is involved more frequently than the second molar, and the pulps of these teeth are vital. A hard swelling may be palpable buccal to the involved molar, and if it is secondarily infected, the patient has pain. The age of detection is younger, within the first 2 decades of life rather than in the third decade with a parodental cyst of the third molar. The buccal bifurcation cyst is associated with multi-rooted molar teeth, with the mandibular first molar being the most commonly associated tooth, followed by the second molar. Occasionally, buccal bifurcation cysts can occur bilaterally, and they can involve maxillary molars as well. The epicenter of the cyst is always in the buccal furcation of the affected molar. On panoramic or periapical images, the lesion may appear to be centered slightly distal to the furcation of the involved tooth because of X-ray beam obliquity. In this picture, note the tipping of the tooth crown in picture A and the displacement of the roots of the second molar into the lingual cortex of the mandible in picture C. The buccal epicenter of the cyst is seen in the compression of the inferior alveolar canal in picture D. In some cases, the periphery is not always readily apparent, and the lesion may have a very subtle radiolucent appearance superimposed over the roots of the molar. In other cases, the lesion may have a well-defined and corticated border. The internal structure is radiolucent. As the cyst begins to enlarge and engage the buccal surface of the bone, expansion of the surface is seen. Owing to the cyst's very slow growth rate, the surface of the bone will remodel to accommodate the cyst. With the expansion of the bone surface, the cortex remains intact but is often significantly thinned. If the cyst is secondarily infected, periosteal new bone formation is seen on the buccal cortex adjacent to the involved tooth. These pictures show occlusal views of buccal bifurcation cysts that have been secondarily infected. Note the laminated periosteal new bone formation on the buccal aspect of the first molars and the abnormal position of the roots of the first molar in picture B. The most striking diagnostic characteristic of the buccal bifurcation cyst is the tipping of the involved molar, so that the root tips are displaced into the lingual cortex of the bone and the occlusal surface is tipped toward the buccal surface. This accounts for the lingual cusp tips being positioned higher than the buccal tips. This tipping may be detected in a periapical or panoramic image if the image of the occlusal surface of the affected tooth is apparent and the unaffected teeth are not. The best diagnostic image is the cross-sectional mandibular occlusal image, which demonstrates the abnormal position of the tooth roots adjacent to or within the lingual cortex. The major differential interpretations of the buccal bifurcation cyst include rarefying osteitis and dentigerous cyst. Rarefying osteitis can easily be excluded because the epicenter of periapical inflammatory disease is located apical to the root apex of the involved tooth, whereas the epicenter of the buccal bifurcation cyst is located within the furcation. Although obliquity of the X-ray beam may superimpose the cyst near the crown of an unerupted, developing molar, the occlusal image will readily show the expansile nature of the bone to be adjacent to the molar furcation. Should the buccal bifurcation cyst become secondarily infected and periosteal new bone formation or sclerosis can be visualized, the cyst could be confused with a periodontal abscess or Langerhans cell histiocytosis. The fact that only a buccal bifurcation cyst tilts the molar as described helps to differentiate it from other lesions. A buccal bifurcation cyst is managed by conservative curettage. Although some cases have resolved without intervention, the involved molar need not be removed, and buccal bifurcation cysts do not recur. Thanks for watching this video about buccal bifurcation cysts. I hope you found this information helpful. Don't forget to subscribe to my channel and check out my other videos on dental health. I'll see you in the next one.